Um,
Hi, I'm Brad Power, and this is our weekly update. This is weekly update number 8, for those who are counting. And we have a slightly different format today. We're going to focus on one question. Linnea is going to give an update on why, but we're going to focus on one question, which is how Linnea should manage the biopsy, which she's planning to get. Linnea, why don't you update us and set up the situation?
okay, good morning or good afternoon all. So I had the scan on Sunday, and when the results were posted, I knew it was bad right away because of this first paragraph being so flippin' long. And essentially, my cancer in some aspects has doubled in size in 2.5 months. And it's never behaved quite so aggressively before. So that was bad news, as was the fact that the report detailed just a lot of collateral damage in my lungs, which ultimately means loss of function. And there's also the fact that for the first time in a long time, I'm uncomfortable. I have a pretty intense pain in my left back now, which is either from the tumor itself or pleural effusions. But anyway, the good news is that tumor burden is not an issue. So the biopsies are a go, and I met with both of my oncologists yesterday. They're both pretty excited and enthusiastic about the biopsy and finding out more information. And they were very much on board with some tissue going to Foundation Med. And then Brad, I communicated with Natera, and they actually need a small tissue sample too, in addition to blood. So, you know, there are 2 slots right there then, Natera and Foundation. At MGH, they're going to try to start a mouse model. And even though I got that very generous offer from Certus, the issue is getting the tissue there in time, you know, because the fresher it is, the more likely that there are viable cells. So fortunately, this is something they can do at MGH too. Now, the other thing we discussed, of course, given the aggressive nature of my cancer right now, is that it would be good to get started on treatment again. And the only kind of best option right now is for combining lorlatinib with a SHP2 inhibitor. And Emily, as you know, this is a trial that was funded by ELK Positive, which is cool. And I will be the second person to go on the trial at MGH. The one thing that has to be ascertained first is whether or not my eyes are normal right now, because the ocular toxicity that I experienced on the MEK inhibitor would normally preclude me from participation. But my team is always going even faster than what seems to be happening. By the time I met with them yesterday, they had gotten permission from the sponsor and the hospital to allow me to join the trial as long as my eyes are normal now. Of course, I'll be followed very carefully by a retinal specialist. As I had told you very early in this hackathon, because I had already experienced ocular toxicity, I am concerned that it could happen again. And so, we just had some very candid discussions yesterday, worst case, best case scenario. And we're all hoping that, first of all, I respond, but also that if I don't, that I can hold on for some other possibilities. And Brad and I talked about when it might be most appropriate to hold a tumor board. And I think given the kind of urgency right now, if I can get into the SHIP2 trial, that's probably my best bet. And I think we will have that tumor board later because everything is going to happen pretty quickly right now. And I should know very quickly whether or not I can be admitted. I will know more, hopefully, about any other acquired mutations. And then if and when I start the trial, I should also know pretty quickly if I'm going to respond or if I'm going to have toxicity issues. And that's it.
Thanks for that update, Linnea. Let me go around to a few folks. I see David Marshak is on. David, you're representing Foundation. I think what would be really useful is if you can, I mean, maybe at MGH you work with them so much they already know what your kind of menu is and instructions for what instructions you would have for the surgeon doing the biopsy. But if you can provide specifications on that in hand so Linnea can kind of take that since you're on the top of the list.
Sure, thanks, Brad. So the options for a tissue sample for Foundation 1 CDX are, it's a routine tissue biopsy, so it would routinely be put into a formalin-fixed paraffin-embedded block. If the Foundation medicine test is the only one being performed on it, the whole block could be sent, but it sounds like there are going to be multiple uses for the tissue. So in that case, unstained slides plus an H&E slide could be sent. It would be 10 unstained slides plus an H&E slide, and there are specimen instructions available. There's a PDF of specimen instructions. I think Kimmery actually summarized those as well, but there's no special instructions needed for the procedure itself. It's just a routine pathology procedure biopsy.
Thank you, David. And then cueing Kimmery, Kimmery, you teed up that table of what each of the tests might require in terms of quantity of tissue and the setup and all. Can you just share that with everyone, just sort of update everyone on what that story is?
Yeah, I'm sorry. I meant to get back into the Slack and put some context around the fact that I just sort of dumped it in there. It was a table that I had been working on for completely different reasons, and it wasn't meant to be specific for Linnea in terms of the test platforms that I actually put in that table, but I thought it's a good template for us to use. So it really just involves kind of doing a comparison across the companies that have come forward to offer to help Linnea to just put down in one place what the tissue requirements are, what the turnaround time and sort of the requirements for the quality of the DNA for each test to have the greatest likelihood of producing a viable result. And can I just ask David, you mentioned the H&E slide. Does Foundation currently digitize those H&E slides by chance?
We do create a digital slide copy, yes.
David, I should also add that, and if anyone from Lucense is on, that Alice Shaw in particular was excited about the return of information on the mutations and variations of unknown significance, because she said that this is something that is being studied right now, and that she's very glad to have this information in reference to my case. So that made me happy.
Yeah, and one other thing I'll put out there as well, if your tumor burden is increasing, if we think back to your liquid biopsy from a couple months ago, and if there's more tumor circulating in your blood as well, you could consider another liquid biopsy if there's limited tissue.
Okay. And you know what? I think we have plenty of tissue now, but it would be interesting to see if anything had changed.
That's a question for me. And I see that John Powers is on, and Chandra I'd like to have speak as well. You have plenty of tissue, meaning there's plenty of tumor site to tissue from. You're still doing a needle biopsy. And the list that Kimmery was assembling, given that we have more than the usual amount of tests possible, can you ask the surgeon to do like 3 times the amount of testing? Is that something that's ever done? And then Grace, I see us raising her hand. Maybe I'll go next to Grace, but Grace in the past has said, you want to keep a third aside for you for the future. And so when you start adding these things up, it's not, you know, it's like foundation gets a piece and you just want to save a third for you. And you want to give some maybe to, as you said, Natera. And then I don't know if, you know, we could have other candidates, the mouse model. What Kimmery was starting to build up was, what's the sum total of tissue required? And is enough going to be drawn? Grace, what did you want to say?
I wanted to continue on that conversation. So my first question was this surgical or a needle biopsy? You know, I think the table that's being prepared or is in process is excellent. That was my suggestion, to have something tangible to really come up with a plan, and actually meeting either with interventional radiology or the surgical oncologist that would be performing this procedure as a pre-game, pre-planning discussion, and saying, here's what we're looking to do. They can look at your scans and potentially estimate what the volume of tissue that is available. But I'm going to play devil's advocate here. I don't know all the locations of where you have tumor that can be sampled. Is a surgical biopsy one shot better than multiple fine needle biopsies in multiple places?
No, it's a good question, Grace, and it's something I'm going to ask. And as I said, I mean, and I've had this conversation with my oncologist before, that I would just as soon get rid of that upper left lobe, because it's been the source of most of my issues. And of course, now it's causing me discomfort too. So I don't know. I don't know what their viewpoint on that is going to be, because, you know, it is a difficult surgery, but now with VATS, hopefully easier. And that would certainly yield so much more tissue. So I have a feeling it will start with needle core, but, you know, perhaps progress. So we'll see.
One more thing, Linnea. I think when you're also talking about this biopsy, will you also need looking at treatment planning, any radiation to that site as well? You talked about collateral damage and loss of potential function and just health of certain areas. If you're going to also be radiating that area, that's another piece of the conversation that someone needs to answer, that yes, even if you do treatment, most likely radiation here, you need to know that, because that really should play into what your decision is.
Thank you.
John Powers, could you tell us about, with your background in sequencing, what are your thoughts on all this?
Well, I used to run a company called Interop Medical that did intraoperative radiation therapy. So on the whole question of Grace's and the biopsy, a surgical biopsy is always going to be better because they can actually see the tumor. They know exactly what they're getting. With the needle core biopsy, it's being guided through imaging. So what you get, what you expect to get may differ. The only problem is there's always more risk, and surgical's got obviously more complications. What we've done at SimpleSeq, the company that I now run, we've got technology that we haven't commercialized yet, but we know works, where we can take a sample, whether it's a tissue, or we've been working primarily in plasma now, so that's why I haven't said a lot on the calls. We can take DNA, when we extract it, do the isolation purification, we bind a single strand of DNA to a covalent bond, and then we can replicate it. So for scarce tissue, we can make as much as you need. We can make copies of it, and we know that what we're making is identical. Mm-hmm. So we could potentially, the question I had was, who's controlling your tissue? If we could get a small sample, we could potentially use our process, or we could send them a kit where they could bind it themselves and then make the copies. So, the nice thing is they can preserve it. So if you wind up out of tissue and you've got 4 other tests you want to run, we can just go back to it and make 4 other copies. It's not, obviously, it's, like I said, this is very preliminary, but if we could talk with your, I don't know if it's MGH or who you're working with, but we could talk to them about doing something. And also, since you're at MGH, they also do intraoperative radiation therapy. So the question that came up on radiation, there is a lung protocol. It was mostly done at UCSF, but it might be something that you could bring up at MGH. But you know, like you said, they've already got a treatment plan scheduled, so it's hard to make suggestions to them, especially because they're the experts there to know what's best. But there are options. I just didn't think radiation was even in the play at this point. But it's been very good for stage 4 and, you know, any late stage cancers, because you radiate during surgery. So if they are doing surgery, that might be an option, but it's at very few places. I don't know, Brad, did that help? Did that answer your question at all?
I did. Let me ask you a specific questions, John, getting very mercenary here with apologies. Should we add Simple-Seq and what you might be able to do to the list of possible uses of tissue? Because it sounds pretty awesome to be able to capture some and then be able to multiply it, so that the whole issue of not having enough tissue, by the sound of what you're describing, goes away. That would be, that's a pretty awesome if true. And then again, to be mercenary, would you be able to do it for free? Because we are not of means, and so any of the diagnostic companies that are working with Linnea are doing so for free.
If you got someone that has a tissue sample right now, and depending on, we'd have to really see if it's in paraffin, we haven't tested in paraffin yet, but we'd be more than willing to provide kits and it's gonna, like I said, this is gonna be experimental testing. It's gonna be beta testing because we don't have commercial product. But going back to Brad's comment, you know, the if true part, which is what people may or may not believe, we got clean data. We know we can do this, and it's 100% replicable, and the results are matching up perfect with the original sources. And like I said, all this has been done in plasma because we started off with cfDNA, but it's basically copying the DNA. So if you got a lab that has tissue that's willing to work with us, we'll send them a kit to let them try it.
So
thanks.
Do you need fresh tissue for that, or can it be FFPE? I didn't catch that.
Well, we haven't tested an FFPE, but we're pretty sure it'll work in FFPE. We just haven't done paraffin. So that's the problem you've got. And it does not have to be fresh tissue.
And how much do you need? How much DNA?
We know that we can do it as low as 10 nanograms, probably less.
I mean, I guess I think about something like with foundation test, if there's leftover, is that something, I don't know, could you?
We're actually, yeah, the only thing I'm worried about is it's preliminary, and that's why Dr. Spinoza brought us on the call, because we're still testing it. So we're still doing a lot of testing. That's what I'm saying. If you've got someone, if it's like foundation, we know very well. We've talked to them quite a bit. If they're willing to do the testing on this specifically, we'll give them the kit. And they know us. We've got plenty of relations with Foundation and Garden and others.
I mean,
but if you guys push from their end, it makes it a lot easier.
It sounds to me like it's a good plan to do with any kind of leftover, right? Like with anyone.
And the nice thing is, with our isolation purification, we tend to, like if you're working with cfDNA, you work with a regular, I won't use any names, but you use a typical kit, you're going to capture about 50% material. We get on average about 98%. So even with small doses left over, we can probably get a pretty good sample.
Well, David Marshak, does that sound like something you could commit to handing off to John?
I think we need to follow up on that. So for one thing,
just set up a call, and we don't need an MTA. We don't want to take material from anybody. We'll send you a kit. We'll send you the IFUs.
Yeah, I was just going to say, when we receive unstained slides, we're going to scrape all the unstained slides to get the most extracted DNA available. So if we receive 10 slides, we'll scrape 10 slides. If we receive 8 slides, we'll scrape 8 slides. We may not need the full 10, but we do retain extracted DNA. So I think if you've spoken with my colleagues, then we can follow up afterwards.
Yeah, let's just talk afterwards, because I don't want to mess with any treatment planning. But if someone's willing to do something else where they can, because most centers, if they can preserve the sample, they're going to want to do that, and that's what we can offer. And we just want to make sure that it's stuff. If it's like Kamari talked about, if it's residual, that's even better, because we're not wasting something. If it doesn't work for them, we're not going to waste any sample.
Great.
So if that helps, just reach out to us separately. More than interested in helping this, either myself or Dr. Spinoza.
John Spinoza sent his regrets today. He has a standing conflict with this meeting, but I'll send an email to the 3 of you and copy Linnea and Kimmery, just making the introduction, and so that you can carry on the conversation or schedule a call, but at least you'll have email contacts.
Okay. Now, I was sorry for laughing, but when you said standing conflict, I was going to say John is a standing conflict, but that's a good thing.
Yeah, you want him on your side, is that what you're saying?
He's a great ally.
So I shall use that as a trigger to ask Devin. Devin, do you have anything to say? Because you're the one who introduced us to John Spinoza. Devin Snedden, did you want to comment on this conversation?
Looks like her screen locked.
Oh, screen locked. Okay. All right. Allie, do you have anything to comment on this thread? You've always been such a brilliant source for matching between the diagnostics and targeted therapies.
Oh, thanks for saying that. Very kind. No, I'm just looking forward to seeing new results, and if and when it's closer to being ready, I can specify more about the types of inputs we take to then more, I guess, precisely molecularly match it to different therapeutic options and combinatorics included. So, and we're pretty, at CureMatch, we're pretty platform agnostic and different types of, tissue versus liquid biopsy agnostic. We just need to know basically what the alterations are. So we're the next step, I guess, after foundation and so on, the GS type of companies. So as soon as we're getting closer to that, I would definitely like to know, and I can give more clarity what's needed.
And like Linnea was saying, when we get to the molecular tumor board, I would see you as being central to that. Good.
Yeah, I'd love to participate. Definitely, anything I can do to help.
Chandra, can you hear me? I noticed you'd been on and off, but we were talking about radiation, going in and getting tissue samples and all. Do you have any comments on all that?
Yeah, I can hear you, Brad. No, I don't have any comments. I haven't seen any scans yet. So really it all depends on what the scans show. The locations of the tumors and such. It's what I can gather, it looks like it's fairly diffuse in the left lobe, right? Like that's what Linnea was saying. So
yeah. So there's Chandra, if you ever have time and interest, we do have 500 pages of scans or whatever it is, Linnea, that's up on Citizen, and she can give you permission to go look at it. So
I will try to do that. Yeah. I was waiting for the latest round of scans. She said they got delayed by a week or so, right? So she got that in now.
Yeah.
Right.
Yeah, I'll look at them.
Yeah, I think Linnea posted those 2 scans, didn't you, in the Slack?
In my blog, and I don't know how well you can see that, but you know, my my left lung is essentially disappearing.
Yeah.
So you know there's a lot of tumor there.
Great. Devin, are you? Thanks, Chandra. Devin, you're able to speak?
I am. I'm sorry. Yeah. I've had unstable internet connection today. I apologize.
Did you have anything you wanted to say? I just think a lot of this is dealing with pathology and such, and just wanted to give you a chance to say anything.
Again, I'll use the caveat that my internet connection has put me in and out of the meeting, so forgive me if I'm being redundant. Is there an opportunity for, and I think John Powers just mentioned the same thing, but it sounds, Linnea, like your treatment plan is set. Would you like a quarterbacked evaluation from Dr. Spinoza and or Dr. Misalek kind of for a second evaluation, or do you need any cohort, I guess, communication with your oncologist? You know, if we go back to that conversation a couple of weeks ago where we were talking about advocating for some of these insights with your oncologist, is that an opportunity? I think other than that, Brad, I mean, it sounds like you have a good plan for the tissue, unless you feel like there's still some wiggly parts and you'd like some help tightening things up with the parsing out of tissue.
Kimmery, you've been sort of quarterbacking the table of possible uses and how much and all. Do you feel like you'd like any help for that, or any requests to Devin?
Yeah, I mean, I'm not sure. There are companies listed there that I think are not involved, and I think there are companies that are not listed on the table, because like I said, I was writing that up for a completely different use case. So yeah, if we could populate that collectively, I'll start a Google Doc, I guess, or a Sheets or something, and put a link in there. I guess the other thought that crossed my mind is we're talking about slides and number of slides being sent, and you know, I think this may be pretty obvious to some, but the cellularity, the tumor cell quantity in the sample. I don't know how carefully that's looked at, for example. So I would say at your end, at your treating institution end, where I would involve pathology is to really get a good sense of the cellularity of each of those slides. So like Foundation says, send 10 slides or X, nanograms of DNA, or how you extrapolate that. But if 10 slides gives excess of that, could you hold back 2 slides? Could you send them 8? And maybe David can comment on that. It's like, if by chance there's really high cellularity, tumor cellularity on each of those samples on each slide, could you divvy up the tissue, not strictly according to the specs that each company sends you, but actually per your exact tumor content?
Yeah, I can comment on that. So, when we're looking at the slides, it's the extracted DNA and the slides combined. So like you indicated, if there's more tumor DNA on each slide, you're not going to need as many slides. We asked for 10 to try to get the best chance at getting results for the most patients. Our first step when we get the slides in our lab is a pathology review. So we're going to look at those the slides under a microscope to assess the tumor content. We're looking for 20% tumor, and we won't even proceed with the test if the tumor content isn't high enough.
A follow-up question: if you find that you have more than enough, what do you do with the excess slides? Would you send them back?
eBay.
I mean, I don't know if we could do something special in this case, but typically we use all the slides we're sent because we still, the more DNA you can get, the higher likelihood of results.
Yeah, got
it. Will LaValle has his hand raised. Will, what have you got to say?
Back to the theme about the radiation. Has there been put in place a schedule for evaluation of whether or not you would be a candidate for any sort of ablative therapy, whether standard radiation or SBRT or some other, including so-called palliative radiation, in order to get a result that can further activate immune response? And I'm in particular thinking about the activation of abscopal activity. Did anyone talk to you about along the line of your treatment plan, considering evaluation from radiation oncology?
No, and it's a question I can broach again, but thus far radiation has not been an option. And you know, I kind of wonder at this point if it's anything they would attempt in my left lung, just because I have so much pulmonary fibrosis going on. But you know, again, if surgery becomes a possibility, then maybe radiation is an option for my right lung, because there is some cancer there too. It's just not as aggressive at this point. You know, as I'm listening to all of you, I'm realizing that before I get on that table for the biopsy, I need to have written down where I want tissue to go. Because even though I feel like I'm getting buy-in from my doctor now, that's going to be the pain point, you know, getting people to do what I asked them to do. I brought up with her yesterday how shocking it was that I did not actually own my tissue, and she didn't say anything. So I'm not sure that was a good sign, but you know, again, these, as has been noted, these academic institutions are pretty traditional, and they've had this certain way of doing things, and it's what they're accustomed to. And I would like you to know that when I signed the protocol for this new trial, they wanted a second biopsy that was just for research. And I told her, no, you know, I'm going to keep pushing back on those, that if there is no return of information, then I'm not going to give tissue. But we are pushing their envelope here. They've not been questioned this way very often.
Linnea, if I may.
Yep.
Brad, I just want to, I know we've touched on this, but once you do have a plan and that biopsy is done, I would recommend ahead of time potentially connecting over the phone or via email with the actual individuals that do prep these samples and ship them out and do some of that legwork if you don't already have those people in your network, because that's where bottlenecks and balls are dropped. Oh, okay. We didn't have a protocol in place for this. Oh, the person that usually does this is on maternity leave. Oh, no, we can't do that. You need to sign this form. And then the tissue sits there and you know, or it's processed or preserved in a certain way that now renders it not usable. So I'm more than happy to connect with you offline and help you divide and conquer those phone calls during the week. So if you need support with that, let me know.
Thank you.
Thanks, Grace. You're awesome. I was going to make the same point, is that in my experience, when I got my biopsies, it was a surgeon. So they were working off of whatever notes were in the medical record. you know, there's not, there's so many opportunities for communications breakdown because you're dealing with so many specialties. And I was going between Dana-Farber and the Brigham. The surgery was at the Brigham and I was being treated at Dana-Farber. You know, it's just, it's almost like you can almost predict, like the old, you know, communication game, that there's going to be some loss of information along the way. And so that's why I agree. I think, Linnea, your request for a very specific bill of materials, it's almost like handing them an order. And so I think, going back to Kimmery, once we build that sheets or that spreadsheet, it can have who's getting what tissue and what are their handling requirements and who are the contact people. We can have those columns in that table. That should go a long way. And it could be, as you know, again, if the table could be as short as 1 page, but it's something that Linnea can have in hand and physically hand it to someone.
Right.
That just seems like it's, and then they can pass it around or take photos of it or whatever they're going to do. Go,
Yeah,
Kimmy.
I think I had sent you also even some, if a company has specs on like the fixation time should be between 14 and 24 hours and no greater, that level of information should also be handed along. I have one question for you, Linnea. You mentioned that your physician was on board with the samples being sent out to like Foundation and others, but do they also intend to do their own in-house panel test? Do they still use Snapshot there, or well, I forgot what they call it, but usually there's their standard of care panel. Are they going to forego that? And can you?
I think they'll forego it. Jesslyn said, you know, she's super comfortable with Foundation and their results. So that would be good. The one place where it sounded like MGH would for sure be proactive is the mouse model. But, you know, again, I need to have as much specificity as possible to get this in writing, to give it to Jess, to possibly get it to the pathology department, John Iafredi, and also hand copy to the surgeon, just so that they all know that I'm on top of this, you know, and that this is important and this is not just a casual ask. You know, I would not be undergoing this if it wasn't so important to me.
I think to Grace's point too, like not only your pathologist, but the histologist, the lab techs, right? They're
okay.
really handling your tissue and doing the staining and the fixation.
All right.
Well, you don't know, people
right.
not have access to, right?
Yep.
Yeah, get it in triplicate back in the old days, carbon paper, and have them each sign it. Grace, anything else? No. Okay.
On mute,
Lars.
but no, I apologize. I'm gonna lower my hand. I'm just saying I'm sitting here also stewing over the fact that just in general, patients are stigmatized and labeled as too lazy, non-adherent, non-compliant, all of these things. Meanwhile, people have no idea what the level of work and heavy lift you have to do when you already have a heavy diagnosis. So we're all rooting for you, Linnea. So please lean heavily on us this week. We want to make sure that no ball is dropped. So don't hesitate to give us a shout.
Thank you so much. And one other thing I will share with you is in discussing the hackathon with both of my oncologists, the part that alarmed them the most was my having my data hosted by Citizen. And I think it was that kind of opening the gates. And I actually found this rather amusing because they have never, and not saying them specifically, but the hospital has never had an issue using my data or my scans or whatever in any way they wanted to. So I think there's a little lack of control here, you know, or I should say potential loss of control that is threatening to an institution.
I'd like to call on Lars, if you don't mind, Lars. I hope I'm not, I feel like I'm in one of those Harvard professors in paper, calling on that person in the back row who's been like, I don't know what you're doing. But Lars, I just wanted, you had such a I don't know, emotional comment when you spoke before. And I was just so inspired by that. So any thoughts or contributions you can make from your vantage point? I see you're driving. And you're on mute. And you're on mute. You're okay. So don't crash.
Hey, Lars.
Can you hear me now?
Yes, please go.
Yeah, okay. Yeah, you know, the clinical side of things are not my expertise, so I'm just kind of listening in here. You know, on kind of the discovery side of things, you know, I know Alice Shaw, of course, is at the top of EML4 ALK clinical research, and there were combinations that were known. She'd be, you know, enrolling Linnea into those trials. SHP2, yeah, has some possibility there. And you know, I'm a little familiar with the SHP2 compound itself. So that's great. In terms of establishing models, I think that, you know, depending on how much tissue is available, right, this decision of what the best use of it is and where to put it, and what having realistic expectations of what the success rate is of each of these. Establishing a mouse model, right, it's going to be extremely difficult. I don't know what the success rate is on, you know, establishing models. Cell lines, similar challenges. Organoids is something that hasn't been discussed at all. Maybe there'd be a lab that would be willing to try to set up an organoid if the likelihood of successfully establishing a model would be higher. That's kind of the thoughts that have been going through my head there. Yeah, if I start talking about the emotional side of things, I won't get through it today. So yeah, we're all here to help. It's just great to see all of these people coming out to help Linnea any way they can. Experts in the field and you know, dedicated people to help patients in non-traditional ways. I just find it very, very refreshing and encouraging for the future.
Thanks, Lars.
Yep.
Emily, we were speaking before we started recording. Is there anything you want to say from the ALK Plus perspective?
I don't think so. I mean, I think it is important now to kind of cue things up for what may be necessary down the line. So, you know, looking at the tumor and the cellularity of the tumor, like Kimmery mentioned, to see, does it look like there are a lot of immune cells in there? Could potentially an immune-based therapy be an option later on? Also, and I haven't kept track of exactly which companies are going to be doing what, but do we have anyone that will be able to do an RNA analysis versus, you know, DNA sequencing? It seems like that could be something, give some additional information. And even there are, you know, I was looking through that trial sheet, there are a lot of new phase 1 type options that are based on targeting molecules that are on the surface of the tumor cell. So looking at whether, and I know Linnea has already been in one of those trials for an antibody drug conjugate against TROP2, but there are some other similar type drugs that maybe her tumor cells are expressing one of these surface markers and could potentially, that could potentially serve as a target down the line. Is there a way to look at the tumor cells for those types of candidates? I don't really know what the options are. And I don't know whether those things would show up in an NGS or in RNA analysis, or if that's something that would have to be done more on like a proteomic or kind of cell staining immunohistochemistry level.
Well, we are trying to get to SomaLogic, which I think was proteomics. So that, okay. That is, but God, gosh, I think they need plasma. They don't need this biopsy tissue. So we're trying to work out the mechanics to get to that. Thank you, Emily. Anything else? Oh, no. Emery.
Wanted to say, I think that's an excellent point, and I think I think last week I brought up the IHC too, and making sure that we leave a couple of slides available to even look at some possible immunotherapy candidates that are out there. Those slides be reused too for sequencing.
I got introduced to those by Bryce Olson, who ended up with a PSMA targeted. So it's a unique neoantigen that sits on the surface of a prostate cancer cell. And then it's radio nuclides that attack it. That's what the therapy he got. So to your point, Emily, yeah, if you can figure out the surface, I guess, of the cancer cells, that can be a vector. Will, you have your hand up.
Yeah, I have one. I want to reinforce what Emily just said about looking down the road for possible immunotherapy. The data right now, proteomic data, really important if it can be factored in to the acquisition of this tissue. And then the same thing with surface molecules that could be potentially therapeutically utilized. Why I raised my hand earlier is that as you're going through, Linnea, and you have all these various pieces, to strongly encourage you to have somebody down here in Texas, we call bird dog the whole thing, so that even though it may seem redundant from your point of view, if you think about it from the institutional and bureaucratic point of view, you have a bunch of people who aren't familiar with this, haven't seen it really before, and maybe they're changing shift when the specimen comes in, and essentially calling and speaking to the various people who are going to physically be handling the specimens, who are going to physically be handling the paperwork, whether it's faxes or emails or whatever they're going to be doing. So you're actually having either you communicating with them or someone else, and then have it in a document. I've often recommended to my own patients a 5x7 index card, and that's for the uniqueness of handing an index card to somebody that has everything in block letters, but it can be in paper. It's something that tells whoever you're talking to what the big picture is in a way that they can understand it when you're not there talking to them. So very explicit and clear. Here's the instructions that we would like from you. And I mean, here's the instructions of the actions we'd like from you, and with no assumption that they understand anything at all. So it's very elementary. So this goes to that office, that's office 4A, and here's their phone number, and the secretary is, whatever that person's name is, and then it's going to go to FedEx by this person will carry it, and we've spoken to that pathology department supervisor, et cetera, so that everybody in the system in each institution understands it. So that gives you much greater likelihood of success and much less likelihood of the ball getting dropped somewhere along the way.
Thank you, Will. Ricardo, you have your hand up. Go.
Yeah, quick question. I know that we're on the top of the hour, but I'm already I'm glad that all these precautions are taken care of and step by step, and it's not too much. Like nothing is too much to be obsessing about this stuff because we don't get to do it twice, so there's no room for error. But I'm already thinking it's done. Where are we on the tumor board? Just to just want to make sure we get ahead of it, so we start already preparing for that.
Good point. We've got a running list of names. It's in a sheet in which I can share with you, or I can put up. But we've got a running list. And you suggested several names to that list, so I think you know that. Yes, that's great. And we're waiting to invoke it when we're a little more clear when the right timing is. And I don't know if you heard Linnea mention earlier, we think she's going to get this ship to that, you know, that ship has sailed. She's going to go to the ship too, and then we're going to monitor what comes out of that. And then it's going to be invoke the tumor board after we find out what comes out of that. So we're probably on like a 2-week lead time to call for the molecular tumor board. These are going to be very busy people. We may schedule on a Saturday or an evening, whatever fits their schedule. But we'll sort of, from the time we figure out that we need it until the time that it happens is probably 2 weeks. And we're just sort of waiting to pull the trigger on calling for those people, because they're not going to show up in these calls every week because they're really busy, you know, high-powered professional types. So Linnea, did I get that about right the way you're thinking about it? She nodded. Oh, you're muted, Linnea.
And I'm still hopeful that as time goes on, I can pull in either Alice or Jess. You know, I think as they learn more about the hackathon and there's more return of information, that it takes on more credibility for them. And this is kind of a learning process for them too. And the one thing I want to say to all of you is this has been a pretty emotional week for me. You know, this is hard news, a lot of hard talks with family members and friends. But one of the things that has kept me grounded is knowing that I have all of you. And I even had a family member say that, oh, but you got the hackathon. So thank you.
Hey, we love you. We love you. We're here for you. We're with you end to end. So anything that we can do 24/7, give us a call. We're in this. I'm a patient too. So I'm in this, together. Did Jesslyn say that she would do it when you met with her on Thursday?
No.
Or was not no,
I haven't gotten the buy-in yet. Maybe if you ask, Ricardo.
We'll get her there. Yeah, no, we'll get her. We'll get her there.
All right.
We'll get her there.
Well, that seems a good note to wrap up on. But John Powers or Jeff Waldron, you haven't said anything. I don't want to leave you out if you have anything you want to say.
Oh, I'm good. I'm just listening in, Brad. I appreciate it. It gives me ideas, and I think the concept of sort of the tumor board is an area that would interest me too, is figuring out who you want to have on the tumor board. It's all tied into the timing of the biopsy and the analysis these various companies can do.
And in that regard, I definitely recommend Allie be tightly tied into that, because we've worked with Allie in the group she's worked with in the past on literally over 1,500 patients for combination therapy. She clearly has great experience in that realm. And Linnea, we're with you.
Thank you.
Glad to help any way we can.
Okay.
Yeah. Brad, one last thing. I would say that as you think about the tumor board, I mean, I know you figured out and designed braces, but if you want to set some time up to think about what is the right design, the right size, the right diversity, and you already saw it once, which is beautiful, because then you know what worked and what didn't work. And I'm going to assume that you're going to start from a bigger audience, and probably 40% are going to say yes or something. But stuff like that, I think, is going to be critical in designing it and engaging with them and pitching, because there's a selling element to it. Because not everybody is like Alice Shaw and like Linnea and like Jess, which know Linnea, the other ones don't. So there's a different approach to make sure that we attract the utopia of the board that we want.
Yeah, and the folks that participated in the Bryce Olson one had a fair amount of interaction with him leading up to it. So they got his medical history. He had one-on-one conversations with him. So your point, Ricardo, yeah, it's not just a invite and show up. There's probably some homework they needed to do to prepare adequately.
Yeah, and that's why I'm saying, that's why I bring it up to do it, to start having that, like, you know, like if you start identifying some, like Ben Solomon in Australia, like we met with him and he's outstanding. But you gotta like start having a dialogue with the guy. I don't think he's a guy that you just show up and in 2 weeks, he's gonna be like, I'm in, if he doesn't know you. So that's why I was like, you know, just think about that as you sequence this or parallel.
Yeah, yeah. Well, and the other thing is that what I found was the give and take. It's like a mini hackathon. And so it's diverse, and then people play off of each other. And I would expect people like Allie and Kimmery to be in that conversation, who have been around and can represent the oh, we had a conversation about that, and what about this? We already thought about this, and what about that? You know, so we can have some of those people, and of course, Linnea. So it's ideal if either Alice and or Jess participate, but I'm pretty confident that we could have a pretty effective conversation, even if they were unable. Okay. All right. Well, this has been a great call. It's about time. And thank you all for participating. I think this was, as always, a very valuable thing, and shows the power and diversity of this community. Thank you.
Good job, Brad. Thanks, guys.
Thank you.